Good evening, and I wore my special professor corduroy jacket complete with elbow patches just for the last two lectures of this course. And this lecture is going to be on specifically the application of counseling theory to opioid addiction treatment. So the first thing I'd like to begin with is I normally recommend finding a foundation, a therapeutic theoretical foundation, and then integrating aspects of other theories into that personal foundation. I don't see that as important with this topic because there's just so much integration needed with various theories. But I would like to start with a basic theory that I think is very applicable, and almost every counseling situation has to begin with some form of trust. And of course I'm talking about Rogerian therapy, person-centered therapy. One of the problems that a lot of students have come to me with, or they perceive it as a problem, is many students have not experienced addiction, and yet they want to work in the field of addiction therapy, treatment, and just because somebody has not experienced a diagnosis or a disorder doesn't mean you cannot be an effective therapist. So, for example, pick any DSM diagnosis. You can be a very effective therapist if you have a thorough knowledge of theory and treatment and experience in the field. So why do people feel this way specifically with addiction treatment? And it's brought out even more so often with opioid addiction. Well, the reason is when we begin to work with clients in the field, they often confront the therapist. Well, what's your experience with addiction? What do you know about it? You don't know how I feel, and what's actually happening there is a defense mechanism. So what they're actually doing is diverting the focus of therapy from themselves because they might feel uncomfortable, and refocusing it onto the therapist in an endeavor to make the therapist defensive or feeling less than, or, oh, maybe I don't know what you're going through. Of course, one slip up, one backstep is okay. I don't really understand. Well, none of us truly understand what another person has been dealing with. It's impossible. All we can do is strive for accurate empathic understanding, doing our best to put ourselves in the other person's shoes and caring about the welfare of our clients. So often I see this reaction as a defense because they're experiencing anxiety, or maybe they don't want to deal with what's going on with themselves at that point. Maybe they don't want to be the focus of attention, maybe whatever. But it is definitely, whether it's conscious or unconscious, it is definitely a refocusing of attention in the session. And the flip side of that is, if you do have some history or experience with drug use or addiction or alcoholism or whatever, I would not recommend disclosure to the client, because once again, it's not therapeutic and it refocuses the attention on to the therapist. So my normal response is simply, well, the focus of this session is not really about me. I don't need to prove that we're equal in some way as far as a history of addiction. In fact, some clients, it becomes almost a contest. Well, whose addiction was worse? You know? Oh, well, yeah, you went through this. Well, it's not really about who used the most drugs, who hit the lowest point. You know, it's not a contest. It's different for everybody. So as soon as I see these things happening, I usually put an end to them. With all that being said, it's still important to build trust. And building trust is not through self-disclosure. It's not through having the same or similar experiences. It's really about caring for the client's welfare and making that known to them. And making it obvious that, in one sense, you're going to do the best you can to help them with their struggle, and yet, ultimately, all you can do is facilitate awareness, which promotes positive change, and get them the resources that they need provided for their own benefit. Ultimately, the choices, the process is in their hands. And I often tell them just that, because I'm there to help the clients, but ultimately I am not enabling them in any way. Counseling is not a crutch in any way. And ultimately, what needs to happen is personal responsibility and personal decisions. And this is not to negate the disease model, but at some point, people still have to make choices. So that's just the beginning. wanting to hear their story, opening ourselves up empathically to their experiences, going in depth into their journey, both previously and their present journey to recovery. I think there's also a difference between judging and appropriate confrontation. So, without judging a person's decisions or setbacks or whatever, I can point out inconsistencies, I can point out incongruencies, and I can basically make some gentle confrontations, and maybe even some not so gentle, but all in an empathic and facilitating manner, in an appropriate manner. So that's kind of the basis of an attitude. The other thing is, a lot of therapists often take on responsibility for clients' failure. And I can tell you now, clients are going to fail. That's part of this process. And it's important to have effective boundaries with your clients, to not take on responsibility for your clients' choices, and yet to make sure that you have followed all of the ethical therapeutic endeavors that needed to be followed for the client's welfare. So that's how I view person-centered theory, trust, and a few of the things that are often brought up in the beginning of therapy. So when I'm talking about client defenses, especially in addiction, we have to look at points of resistance. If a client is resistant, then that can take a number of forms. But, for example, it could take the form of not wanting to talk or participate, defense mechanisms like changing the focus of the session, or trying to focus on the therapist or question the therapist's experience or abilities. It could be changing the subject, becoming too familiar, joking, lots of forms. But the root of resistance is anxiety. So something is spurring on the need to escape the topic. So when we say a client is resistant, then they're displaying one of those defense mechanisms. And the way I see it is, I don't see it as, this is a difficult client, or this person is being difficult. I see it therapeutically. When I see a client becoming resistant and displaying one of these defenses, I know that something is either going on with the client that day, they're struggling with something, and they're experiencing anxiety and don't want to talk about it, or I'm getting close to something, maybe a topic, a struggle, something they experienced, and it's bringing up anxiety, or they're struggling with the addiction itself. Anything from cravings to a comorbid diagnosis. So let's move on to the next theory. This CBT is one of the most commonly used basic theories in addictions treatment. And the reason for that is because it matches the cycle of addiction so well. And it really matches opioid addiction and the cycle of craving or relapse extremely well. So the reason it matches so well is because of CBT calls it distorted cognitions, and REBT calls it irrational thoughts, but they're basically the same concept. Think about somebody who's struggling with an addiction. When would they really incorporate irrational thought processes? Well, when they're struggling with cravings, when they are triggered, when they're moving up that grade in the cycle of addiction. Remember, we talked about the curve and the valley, and perhaps they're struggling with some anxiety, or addiction cravings are kicking in, and first they're feeling pretty good, but then these things start kicking in, and maybe anxiety, depression, some PTSD, something else that's going on with maybe a comorbid diagnosis, or simply a craving because of physical and emotional and psychological cravings as a result of the addiction. And then stressful things begin to happen in their life. So the anxiety and cravings heighten, and the way they used to deal is through self-medication, using whatever drug, in this case opioids. And then, as soon as it heightens enough, they begin the irrational thought process. It could be an irrational thought. It could be a rationalization, which is also an irrational thought. But something is going on because their brain has a slightly different cognitive mapping now. It's connected with a reward system. It's dealing with cravings and withdrawal, and our minds work in very sophisticated ways. So they are probably not conscious of the way their minds are using irrational thoughts or rationalization. Okay, so it could be just this once. It could be I need this. It could be, think about any excuse or rationalization or irrational thought that might come into a person's mind who's struggling with an addiction. Okay? So we could go with straight CBT, but I usually prefer kind of the modified REBT because most clients can really understand the ABCDEF process. And that process really fits well, once again, with the cycle of addiction and triggering and irrational thoughts, relapse and using. So I actually teach my clients REBT, CBT, primarily that cycle of ABC. And then we move into, okay, well, what are we going to do about this? Well, we incorporate DEF. So let's just talk about how we might do that. So when we're thinking about it, A, activating event. Okay, well, in addiction, that would be a trigger, okay, or a buildup of anxiety-producing events, or days into a craving, or a combination of those things. So then we have the belief, a belief about the activating event or the trigger or whatever is going on that allows the anxiety to build so that the client wants to use or self-medicate. So the belief in this case is sometimes rational, sometimes irrational. The rational component would be I'm feeling sick. If I use, I'm not going to feel sick anymore. Okay, well, that's a physical condition of withdrawal. But later on, it becomes a more psychological, irrational belief. And people begin to bargain with themselves in their minds. They begin to rationalize the process of addiction and using and relapse. The other thing that comes into play is the comfort that takes place with the ritual. And remember, we talked about the ritual, and even when people begin to imagine the ritualization process of using a drug, the mind begins to react chemically. It's very Pavlovian. And so once that occurs, that's A, B, then C. Then there's a consequence. And in opioid addiction, the consequence is usually relapse and using. So when we begin to talk about that process, of course, the first part is education and understanding. So facilitating the awareness of what this mental process is that's occurring. So through awareness, people then have the ability to choose and make positive changes. They also have the ability to substitute a positive decision for a negative decision, which would result in a more positive consequence. So when we begin to teach them this process and apply it to opioid addiction, we deal with both the physical cravings and the emotional / psychological ones. And we ask the client to bring up, okay, well, what is the irrational thought process that usually wins in your mind? and I have them voice it out loud. And it might be multiple ones. But once they voice it, that takes power away from it, because it is now identified as an irrational thought process. And it's seen for what it is. So then, once a client is aware, once the client's aware of the thought process, it's no longer unconscious. So they can no longer buy into the irrational belief. They can no longer believe the irrational thought process. There's no more excuses for buying into the irrational thought or the rationalization. So then they have to consciously make a choice. Okay, I know what's going on in my mind. Now I have to make a choice. Am I going to use or not? That becomes the choice. It wipes out the irrational thought process. That, I would hope, as a therapist, is a much more difficult choice than a rationalization, of which they might be conscious or might not be conscious. So, the second part, DEF, we teach them, okay, so what do we do about this? Well, okay, the first thing is we identify the irrational thought, okay, so, and we debate the irrational thought, or we teach them how to debate the rationalization or the irrational thought process. And the easiest way to debate it is simply to tag it, to identify it. Okay, this is my addiction, talking. And I often separate the addiction from the person. A person is not their addiction. So many times a person identifies themselves with the addiction, but a person is not their addiction. We need to separate the addiction from the person. The addiction is a struggle the person needs to overcome, but it's not who that person is. And once they have that boundary, that distance, okay, that's the addiction talking. That's the way it's reworked my cognitive map. That's the way it's reworked the reward system and the self-medication system. And this is the way I was dealing with anxiety or a comorbid diagnosis or the stresses in my life or the physical cravings or whatever it might be. First thing they have to do is debate the irrational thought process by identifying it, naming it, and then they're able to make a clear choice regarding that thought. Okay, so what are the choices? Well, oftentimes we might think it's as simple as saying no. Just say no. It's not. That's where a support network can come in. Okay, so it's important to create a support network. It's important to, and that's what's good about 12-step programs as well. Not only the steps, which are important, but also the support network. Now, eventually, I would want the person to become more and more and more independent as time went on. Okay? But there is a time for support. But we need to find out what will work or what will help that client when they have that choice to make. Once it's identified and labeled and, okay, here we are, making the choice. What's going to help them both to clarify and to deal with it? So once they make the successful choice, which would be saying no, to using, what then? Are they just stuck with the craving, stuck with the anxiety, stuck with the comorbid diagnosis, whatever? Are they just stuck? No. We need to move further. We need to address the anxiety. We need to address the comorbid diagnosis. We need to address the need for support. We need to take that extra step. So whatever is going on, we need to help facilitate some success in dealing with them saying no. What's the result of them saying no? The ultimate result is positive. They're not using. But there are many other results. Then they need to cope with whatever they are left with, whether it's the craving for addiction or the emotional needs or whatever it is. We need to help them find some resources so that once they're able to say no and identify it, okay, then this is what I'm going to do next. A plan of action. Okay, this is what I'm going to do next. It could be anything. It's whatever works for the client. But we do need to have that plan of action with the client. So here we have the effect, and I would call that, the plan of action, the positive choice, and the result F, a more positive feeling. As a result, a sense of satisfaction in making a good decision and moving forward in a positive direction. So we can really incorporate both CBT and REBT with not only the addiction cycle, but also treating the addiction therapeutically, and not just allowing a client, once they've said no to using, allowing them to suffer with whatever's left after that decision. We need to help them to address whatever is left over. Okay. We're at 30 minutes, and I know it's difficult to upload a video for me after 30 minutes. So this is going to be part 1, and then we're going to come back with a part 2 with more therapy, and then we're going to make a couple more videos. Okay, part 1.